Let's talk about stereotactic ablative radiotherapy. It's a technique standardly used for treatment of stage 1 non-small cell lung cancer in patients not suitable for surgery. Dr. Suresh Sanan, my guest, and co-workers did a population-based study to see what the impact is of this technique on the survival of patients over 75 years. And the study was presented here by Dr. Haasbeek. You compared data collected by the Netherlands Cancer Registry for 3 periods. Can you describe these periods?
We introduced stereotactic radiotherapy in the Netherlands in 2003, and a previous study in North Holland suggested at that time 40% of elderly patients were untreated, mainly because they were considered unfit for surgery, and because the conventional radiotherapy involved 30 to 35 visits, and many of these patients didn't want that, and the results were not spectacular. So the first period we chose was before 2003, where the entire Dutch population of 16 million, I must add. And the second period was when we started stereotactic radiotherapy in North Holland. And the last period is when the rest of the Dutch centers decided to implement it. And when we talk about specialization, at that time only about 9 of 22 centers did so, because it's a highly technically challenging procedure which requires good quality assurance. But because our local control rates were so excellent, we thought, to be believable, we have to detect something in a population. So we did that in North Holland, where we showed it increased survival by about 6 months. But the Dutch national population with 4,600 patients is a much more exciting target. And the two key findings are that survival is improving, overall by about 8 months, and in the radiotherapy group by about 9.6 months. And in the surgical group, the mortality is dropping to, I think, 30-day mortality is dropping as well. So we are seeing improvements across the board, but the magnitude of improvements after stereotactic radiotherapy were quite astounding. And interestingly, the percentage of operable patients remained the same. And what increased was stereotactic radiotherapy use.
Alternative.
Yes, that's how we see that information in a group of patients who are above 75, who are not good candidates for adjuvant chemotherapy. So even if you don't stage the mediastinum that well, the surgeons do, you still get a very meaningful increase in survival.
So maybe you have to choose stereotactic ablative radiotherapy above surgery.
I believe that the data and the growing body of data has led to lung physicians referring more patients, but I do not think it's... I think there are no trials comparing the two yet, but there is a reluctance in the Netherlands to commit even fitter patients to trials, which is why we do epidemiological studies, because that's the best way to find out what's happening in the real world. Even if I did a trial limited to very fit, selected patients, the question will come later. How does it apply to my average practice? And that's where this information is very useful for the medical community. And increasingly, we're going to patients, because we want to know how patients are informed, what they are told, and how what is the desire to make this.
You're talking about people above 75 years. So
75 and above, yes.
So the question is, do they know if there is an alternative, or do anyone tell them?
Yes, I believe many are being told, but are they being told appropriately? Do they also see a surgeon? Do they get... is it so in some practices they're getting all the information on stereotactic radiotherapy but not appropriate surgery? Is stereotactic radiotherapy approached in every patient? A big T2 tumor close to the blood vessels may have a very high risk of occult nodal disease, and that's what our data shows as well when they are operated. So I think we have to accept that there are two curative options. We have to accept the limitations of what we know and don't know, but I think it means that they have to be discussed in an expert multidisciplinary team.
I think that's the point, right?
Yeah. So
where the mortality figures are known, and we know that academic large volume centers or any large volume center has far better diagnostic and treatment results.
What's your opinion as a surgeon?
No, I agree. I mean, you have to understand, I don't know what the average age of diagnosis is here in the Netherlands.
72.
Same in the U.S.
Yeah.
So the average age is 72, which means there's a lot of patients who are over that age who get diagnosed with lung cancer. And to look at a population of 75 and more, I think that's key. It's a huge number of individuals in whom the options were limited. And this is, I think, for many of these individuals, a good option. I agree. The decision needs to be made in a multidisciplinary panel. I think, actually, what I like to do is I like my patients to meet with a radiation oncologist and hear what the radiation oncologist has to offer and say, and have the patient make an informed decision on risks and benefits of both. It's attractive. You know, there's no incision, there's no pain, it's fast, there's no risks of surgery. But then there's also right now the unknown.
Yeah, so you're also talking about the empowerment of patients.
I think that's very important.
Yeah.
I think what's also very important is the extent of the staging up front. I think that's more or less key to whether you can decide to do stereo or surgery. And that's why I think these multidisciplinary teams are also important. In order to get proper staging, getting the right patient to either one of you. Okay.
Is this the key word of this conference, multidisciplinary teams?
Specialized multidisciplinary teams, maybe.
Yeah,
I think so.
It's been used previous conferences as well. I mean, but no, I mean, I think it's becoming more evident that all the specialties now have more tools, and we need to evaluate the pros and cons of it all when we meet with the patients.
I would like to add that it's a term we all use. We know what we think it is, but it's not well defined. I think it should be mandated within who do you need there. But one thing I find missing is that we talk about personalized medicine, yet patients with stage 1, in my view, are not given good information. It's another study we've done which is not presented, where we looked at, in a country with such spectacular results in acceptance of stereotactic radiotherapy, we looked at the sources for information available to patients on the internet, on hospital, National Cancer Registry sites, funding bodies, and it's been dismal. It's scored very low. Patients are not getting that information, in part because the changes in a short period for stereotactic radiotherapy have been fairly spectacular, and it's, you know, the mature data is just rolling out. So that's what we didn't have for 5 years, what happens. But if you look at the first 3 to 4 years, we have a good basis for comparing. And I think for personalized medicine, you have to give the selected group of patients who desire to know more the options in a neutral way to say what the pros and the cons are. What's the option if you choose one and tumor comes back? I think that's where a lot of our research effort is going to go into in the next 3 years in Holland anyway.
Well, personalized medicine does not apply to stage 4 only, right? I think that's the message, I think.
Definitely.
There's a lot of focus on advanced disease and not on the early stages.
Thank you. Thank you very much. Eric Valliere and Suresh Sanan for your explanation on these important issues. And Egbert Smith, thank you for being at my side for your critical questions. This was an Oncology TV program from the World Conference on Lung Cancer in Amsterdam. We want to thank the local organizing committee and in particular the conference's president, Professor Peter Posmus, for their support, and we thank you for watching this program. Maybe till next time.